So I'm going to talk to you a bit about our experience in decision support, clinical decision support, particularly around pathology, and start to look a bit forward around what's happening in machine learning, because there's been some huge progress in the last 7 or 8 years in this area, and it's quite, I believe, going to be a huge impact into healthcare gradually. So Alcidion is a health IT company based in Adelaide. I'm a Chief Medical Officer, co-founder. We do stuff in the emergency department, around patient flow, outpatient clinics and general clinicals. My background is I studied medicine. I don't see patients anymore. I did a PhD in decision theory and probabilistic systems, thinking that that was going to help healthcare, where we've got very much more basic problems at the moment. So we haven't yet got to all the cool algorithms I was playing with 20-something years ago. But a firm belief of mine and Alcidion's is that technology should play a more active role in healthcare. I mean, a lot of the systems out there at the moment, some of the more expensive ones we've been talking about today, really treat healthcare IT a bit in an analog way to paper, really just presenting paper in the computer and still expecting clinicians to have to go and seek the information and understand it, rather than being able to understand the information and the informatics of it and push that up to people. So pathology horizon, so let's just look generally about what's on the horizon. So looking at some data from 2050, and this is some things that have already been covered today, but we know that per 100 working Australians, the number of people over 75 is going to double. The number of people over 85 will increase by 2.3 times. The population that is over 65 will be, the percentage of the population is 40%. And hospital costs, not by 2050, but by in the next 10 years, is going to increase by 2.5 times. And so can healthcare scale to support this? And this is a really important question, because if you do the maths, most of us in the room are going to be up in those red squares, right? So we're going to be that population who are going to be a burden on the healthcare system because of all the chronic disease and increased incidence. And so you can worry about climate change, but that's really your grandchildren's problem. This is actually our problem, so we should really be thinking about this even more so. And, well, what are we doing? We've got a great healthcare system, high level of expertise, very significant dedication and education, but in all of that, we still have around 15% of multi-day episodes in hospitals have some adverse events, and it depends on how you measure it, but you know, we're not talking about 6 sigma levels here, we're really about 1 sigma. Clinicians spend about 30% with patients, 70% doing other stuff, and that hasn't really improved with the IT technology out there. Studies have shown up to 40% of lab results are not even seen. So all that hard work you do in getting the stuff ready and high quality and all the QA kind of gets ignored out in the clinical environment. And even if people do see the results, then often they don't do the right thing. So this is for ST-elevated myocardial infarctions. 30% of people don't really get on the right guidelines on discharge, and it's even worse for non-ST-elevated. So what is that? So we've got problems with scaling our existing model to meet the increasing demands. We're really, you could argue, as part of, compared to other industries, not doing great with our error rates and some of the inefficiencies. So what are we talking about? We know this is a common thing. We've got to get community-based care, and as Damien has pointed out, there's a lot of unmet need out in the community, particularly say with chronic kidney disease, but other areas as well. We've got to manage those people earlier and keep them out in the community. The personalised medicine has been taken over by the genomics guys, so we're talking about precision medicine, which is not just genomics, but just about managing therapy and treatments on an individual basis. And we've got to keep people out of hospital, because hospitals are dangerous, expensive places, you know, with infections and all sorts of things. But how do we do that? We have years of waiting lists for outpatients, we have ED blocks, significant percentage of healthcare dollars is really spent in the last months of life, and out in the community, it's quite difficult to organise logistics to keep people out of hospital. And again, these are logistic and planning issues. So some of this isn't even clinical, it's just really the organisation of healthcare. And as you get more team-based healthcare, that becomes more complicated. So I'm just going to paint a view, which I'm happy to, you can argue with me about it later in the panel, but here's what I guess the future of healthcare needs to look like. To keep people out in the community, we're going to need lower cost/skilled healthcare workers supported by clinical decision support. We can't say for every patient out in the community you've got to send a nurse and a physio and a pharmacist and get people out there collecting data that is structured, that can be integrated with, say, low-cost tests, patient self-data collection. Obviously, the finger prick testing isn't going as well as we all thought it might, thanks to the FDA, etc. at the moment. But as we go forward, there'll be cheaper tests. They're not going to be as reliable, but there's some information being gathered, integrated with data that patients are collecting and storing on their phones, which has become really the healthcare hubs for patients. And that data needs to come back and be monitored by decision support that can identify when a patient's trajectory changes and when to escalate to the right, more expensive resources. So monitoring therapies, comorbidities, and integrating current patient state and planning that is compatible with the patient's preferences. So in all of this, we've got to make sure that we are identifying what is needed for the individual patient and what their goals are, not just, this is the protocol that they're going to be on. And quite frankly, the fact that you have ED blockage, emergency department blockages or ramping, shows that we really aren't great at having a uniform criteria about who should actually be in hospital. I mean, are we saying the person, with a leg missing, is lying on a ramp is the least sickest person in the hospital? There are people, the criteria for discharging patients is not really clear and understood. So, I think there's got to be more objective criteria. We've been doing some experiments with what we call quiet patients, where we monitor when pathology tests are not being done or stable on patients. And we're saying, well, why is that patient still here? And I'm not trying to really deprecate clinical expertise. I'm just saying from a logistic point of view, it really should be relied on for exception-based decisions when we're overriding what is objective criteria because of specific clinical or patient needs. And that's completely understandable, but we do it without having to fight opinions, which are difficult. So, the effective use of pathology is obviously essential in all of this if we're talking about systems that we're gathering data and being able to try to manage people out and stay out of hospital. So pathology is obviously a great driver of clinical decisions and therefore resource utilisation. Early detection of chronic disease. Why should we be hunting through GP systems when really that should be going centralised? If the creatinine's up, it should be registered and that set piece begins. So you don't have to convince people. We shouldn't have to argue opinion. This should be a set piece. And at the moment, because of that governance and we're thinking about crossing into other people's domains, we're just talking about egos and clinical egos here. We're not talking about what's best for the patient and what's best for the healthcare system across its sustainability and in the future. So therapy monitoring, as we talked about, is another issue. And that's really going to become more important, as we've seen with the genomic side, but also increasingly with multi-resistant bacteria, where therapy is going to become more like game theory. You're going to do something and then measure the response and then being able to, based on that response, apply another therapy. It's not going to be a static protocol so much. And so that dynamic nature, that game theoretic kind of nature against whether the cancer or the bug is going to play an increasing role, I feel. And comorbidity detection. A lot of comorbidities are just measured because the person comes into ED with a headache, their kidneys are off, it's not the main problem, they go home with aspirin. But actually the junior doctors, which is where most of the variation is, don't elevate that and measure that comorbidity. So the precision side is integrating the pathology data with the genomics, observations, and as I said, preferences. And that's really hard to do. That's a very hard thing to do. It's a lot of information. We just have a hard time looking at an electrolyte screen and being able to identify consistently the patterns in that. So we know that clinical decision support has a benefit in reducing variation, reducing error, improving compliance to best practice and decreasing length of stay. Though the evidence out there is very strong, it's been out there for 30 years. It's not guaranteed though. Just plonking in technology doesn't guarantee you these benefits. As the saying goes, just buying a new phone doesn't guarantee you better conversations, despite what I tell my wife every year when a new iPhone comes out, but it doesn't. And in fact, you don't solve problems by accident in healthcare. You have to target them and hunt them down because healthcare is complex and difficult. So this has been embodied in the HIMSS MRAM, the Electronic Medical Record Adoption Model Maturity Scale, which says, well, just getting your basic lab, LIS, RIS-PAC stuff and pharmacy is just the entry point, but the maturity level goes up, and you can see that decision support and structured data play an important role because that's where the return on investment is for your IT and the clinical benefits. And that's also been embodied to a degree in the Meaningful Use, the HITECH Act that's driven Obamacare. Now, having said that, a lot of these benefits haven't been realised, and there's a whole lot of US Senate Commission hearings going on because of huge investments into health IT, which have very low user satisfaction and very low benefits at the moment. So again, that stuff doesn't happen by accident. So from Alcidion's point of view, we started off over a decade ago realising that pathology results were a key problem area, particularly in the emergency department. But also, it was a great opportunity to save people time. In our view, and being, as a clinician, time is the big barrier into clinical engagement. We can try to convince people that it's the right thing to do, but ultimately people want to get home on time. And so we need to be able to make things faster. We have to make the right thing to do the easiest thing to do. Because if it's not, then you get, when you go to these change management meetings, people are talking about heroics. Heroics comes up a lot. It shouldn't be heroics to do the right thing in your job, right? That's, in other industries, that's not acceptable. In healthcare, it seems to be okay because we don't really value clinical productivity as well as we should. So what we've done is, and we've got some good results. We know that people get to results faster. These dashboards, visual dashboards, allow people to peer review. So for example, the creatinine problem in ED, the CRP problem in ED, where people come off medical units and start ordering CRPs on everyone. I had an emergency doctor say they wanted to put electrodes on the genitals of every intern, so every time they ordered a CRP, it would go off. And technology's not quite there. Genital electrodes that are Bluetooth enabled are, don't Google that. Don't Google it. So the other area, as pointed out, were missed results tracking. So results coming back after people go home, and as Ronan was talking about, why are people ordering stuff on the last day? About 10% of labs come back post-discharge in some of our analysis, and then you've got the histo and other things. So just show you sort of the stuff we're doing. So this is a product that's been out for where's the mouse gone? Here we go. For a long time. This is stuff that we were doing some years ago and is still out there. So green means normal results. Every patient gets a row. Green means a normal result. Orange means some abnormality. Red means critical, and that can be defined by the unit. Grey means it's a text field and we can't interpret it. So it's very bright. So people, if there's a lot of red, you know that there's a lot of abnormal results available, and you can quickly get to review the results. And it also does things like showing you length of stay and different NEAT targets, etc. But access to that information was really important. So this is what we've been doing in terms of speeding up the workflow. If I can find my mouse again. Oh, there we go. So speeding up the workflow in this case was using RFID. So you click on that button, you see you can't accept the result, you can't witness it because you're not logged in. So logging in, we had to make really simple so we know who is witnessing what data. So you swipe your card, logs you in. The goal was to get you the data in under a second. So now you can accept the result, and when you accept that result and click on it, the colour fades a bit, so you know it's not so bright. So anything bright is unmanaged, anything bright and red is really important for you to look at, and CRPs, you know, you can see in peer review. And so this is stuff that we just have to get fast and quick to use, and it does a bunch of other things. This is a missed results or Maya tracking or missed results tracking. So this actually brings back all the abnormal results, and you can set up a variety of criteria like all the histo and radiology, and it allows you to track, I think that's working, I don't know. It allows you to track the results. You can look at the results, say I don't want any action to follow up on, or you can set actions, and it's a full audit trail to say, well, who do you want to contact? So it's really closing that loop with a full audit trail, and it also gives you, if you look at by doctor or by follow up up the top there by doctor, it gives you, who's not checking the results and who's not following them up. And that sort of thing. Now, what was really surprising to me was how difficult this is to actually get into clinical practice. We thought this was very cool and very important. It's pretty quick to do that. But actually, the clinicians outside of emergency departments are actually very hesitant about tracking results because they fear that they're just going to get a lot of spam. You get safety and quality people saying, yeah, this is a good thing, but the clinicians are a little bit hesitant about it. And that's been difficult and a bit disappointing. But again, we'll talk about some of the drivers that can improve that. One of the really big areas in terms of understanding what pathology means and what the computer can do for clinicians is the context. Otherwise, as we heard about, you just get alert spam coming out. So clinical context is important, and again, we're talking about, we're trying to shift to say the machines need to be able to understand the clinical context. And so that means structured data. And structured data requires concepts that are coded into some standard terms. So interoperability isn't just about shifting paper records around, it's about records that the computer can understand. So if someone's got diabetes in one system, we know that it is a coded term that is not relying on a clinician to read, but the computer can understand and make sure that across the continuum of care, the appropriate protocols and standards are applied. And so that might be LOINC or SNOMED CT. The problem, SNOMED's kind of a mess. It's difficult to use, so there are some technical issues still going along in that. And then outcome data, and the outcome data is going to be coming, as we get onto machine learning, outcome data is really important because we need to capture the outcomes so we can train ourselves to know what's good to do, but also train machines as well. And in a $115 billion industry in Australia, healthcare, we don't really capture outcomes, which is kind of unusual, not in a structured way and not in a routine way. So I'm not going to spend ages going through any of this stuff. Happy to talk about it later, but just an example of structured data entry. I'll just scoot along here. So this is a patient about to be referred to for a procedure. They've got an INR of 2.8, which is therapeutic. Let's just go on here. And this is a structured data entry, so autocomplete off value sets, if you like, or reference sets. Coding in the background to SNOMED and ICD is required. Bringing forward pathology results. So anything that's been entered, you don't re-enter, it comes forward. As you enter data, we'll just scoot along here. Some of this. So as you enter data through here, it can also calculate scores, for example. Oops, where's my mouse? Let's go on here. So, this is a CHADS2 score. So as you enter data, it's just calculating those scores, and then as you continue, we'll just go down here, and you can see that an order set is created, and so that is customized for that patient. So the idea is that you can capture that structured data, and also when that procedure is done, there is an alert to say that this patient's INR is now at a dangerous level because the context has changed, because the patient is now off for a procedure. This is something we're doing with ordering. Again, we're talking about order set compliance. Again, make the simplest thing to do the easiest thing to do. So we've spent a lot of effort to make ordering an order set super quick. So this is based on some clinical data. So the order sets are recommended according to the clinical presentation. This is obviously a Northern Territory one because it's snakebite. So up there, you can confirm the order. That's your order set. Click it again to confirm, and that's it. That's your order set, and it also can track, add-on orders and so forth if you're configured by default to do add-on orders. So again, making that, again, every click or tap that you're asking a clinician to is pushing a friendship, really. So you've got to make it super quick, and in this, and that you can say, well, that was a pretty simple one. Oops. I think I've just jumped around a bit. Sorry, I'm not exactly sure where. Oh, here we go. So looking at this very, very quickly, again, this is a more complex one where you might have chest pain. Again, this is just dummy data here, so you can see previous results. There's an optional component, so you can order that. And then going to an ad hoc, which is what we kind of don't want them to do, is an extra click, and then we have traffic lights here. So if they're a junior doctor, they need to put in a reason. You can configure the reasons. And that's so that senior doctors, because the whole other game of health IT is not to annoy the senior doctors. This is not worth the trouble, quite frankly. And so the senior clinicians who don't have to put in a reason, they can kind of do what they want, and it's really up to their peers to deal with that. That's not an IT issue as far as I can see. So what's stopping us from these kinds of improvements about IT playing a more active role in healthcare? Well, we need clinical engagement. You kind of get that. It varies, and as Ronan was saying, we're often relying on an individual to help, and we don't really have a mature sense of chief medical information officer. We haven't trained people in informatics here. Partly my fault because I closed down my unit at Adelaide Uni, and because it's just too hard to get funding in Australia for health informatics. Leadership. So in terms of clinical leadership and engagement, so health IT systems aren't guaranteed of improving productivity. In fact, they can lower them, as has been seen in the US through these large investments. We don't really foster leadership in that. Safety focus. Nope, boards don't get sacked for safety issues. They get sacked for going over budget. We get reimbursed for errors here in our ABF funding. So you can, you get reimbursed for error codes. You can change primary diagnosis after the patient's been admitted to get the higher reimbursement, and you get reimbursed for readmissions. So a whole lot of levers that for safety aren't activated in our current ABF model. Flexible IT, possible, but not usual. It's difficult to, after you spent the 300 million or 400 or 500 million to actually modify it to work for specific units. Each unit is really a different business. In the hospital has their own priorities. And I think the technology point of view, we kind of, so it's not really a technology problem. I think we have the algorithms and all that stuff to improve and do this stuff. There's a whole lot of other stuff that isn't aligned in the system to really look at this. And look, as I say, as I keep saying about myself, you have to be a pathological optimist to be in this game. But that's really in keeping with Hugh's positivity. Really a lot of those things are really about awareness and getting people, getting systems in place. So, just some of the nitty-gritty of what we've found over the last decade or so in dealing with pathology systems. This sounds a bit whingy really, but deduplicating labs, HL7's always a problem because everyone's got their own variation of it. The biggest problem is sequencing actually. So, labs going from final back to pending or UR numbers changing without delete messages, because we're going to be activating decision support on this, so we need to know if something's changed. And then the good old one where assay units are just changed without notification. So the idea is that with pathology, machines are going to be on the end of this, and we need to be a bit more careful about how we manage that data and the quality of the data, because we want to trigger a whole lot of things off it. So that's a kind of a whirlwind tour around where I think a lot of clinical decision support can be, and what we've been doing in the area and working with clinicians around it. I think the bit that kind of has to flip for people is to start thinking about computers as playing a more active role, as I said, in healthcare. So in the last last section of the talk, I was just going to give you a view on what's coming even further around deep learning and the next stages of clinical decision support. And so you may have heard of deep learning because there's been some publicity around it. Google, Facebook, Microsoft, Apple even have all been investing heavily in deep learning. And that's been coming out with improved vision and image recognition, speech, the way we speak to our phones and our devices, the way they speak back to us in natural language generation, and increasingly with self-driving cars. So Tesla, I think a few weeks ago, sent an upgrade out that will allow a lot more automated driving. And so a neural network, and I'm going to talk about neural networks a little bit and kind of demystify them a little bit. So a neural network, that's the simple kind of neural network on the right. So you have input parameters, and so it might be, say, 5 lab tests or a set of the signatures, for example, coming in. You have hidden layers, which is where all the mystery happens, and then you have some output that is the prediction. And the networks are getting huge, 15 billion or 160 billion parameters actually recently. So if you think about a linear regression model, for those of you who've done a bit of stats, let's say you have 4 inputs, you have 5 parameters, right, on a linear regression. You've got one for each input, and then your intercept, your beta 0 to beta 4. You're learning 5 parameters. Here we're talking about 160 billion parameters, and that goes back to your diagram, with all those knobs. You've got to think of neural networks as having huge amounts of knobs that can be fiddled to fit some purpose. And so the networks are deeper. So this is how kind of each of those stacks is a set of those hidden units, and each of them are kind of processing the image in a slightly different way and looking at different features and then coming out with a prediction or an assessment. So this is really getting to a huge level, but to fit all those parameters, you need a lot of data and high quality data. So what's interesting here is if you just look at the first diagram and just ignore the shading, but look at the dots, you see that, let's pretend that that's a prediction. So the red are the patients who maybe don't do well, and green are the patients who do quite well. And you've got on the X and Y might be two assays, for example, right? Two numbers that you're counting. And you can see that the way the red dots and the green dots are mixed, you can't draw a single line that is going to separate the green dots from the red dots, and that's called linear separability. So that's where our linear models work, right, in like regression models and a bunch of the traditional stats models. So what neural networks do, because they have lots of knobs to fiddle and they can shape themselves around, they can, and so you can see over there was 20 neurons in the hidden layer. It can actually shape itself, and for those of you who do some stats, that's also a problem with overfitting, because we've kind of really customized the curves around those areas. But you can imagine that now with thousands of inputs, so you get very highly dimensional, complex networks. The other area is that we can handle correlated data, and this is a bit subtle, but in traditional statistics, if data is correlated, like let's say you have a lab test that's a bedside test which is not very reliable, and you have a good pathology test or a histopathology test which is much more reliable, they're correlated, they're measuring the same thing. You throw out the less reliable study or test because you can't put them both in your model easily because they have to be kind of independent. And the problem is those weaker tests are the ones you do earlier in the case. They're less expensive, and for monitoring purposes, you want to be able to do those tests and incorporate those in the models. And so being able to handle correlated data is important because it allows you to not be over or under confident when you get two tests who are measuring similar things but with different reliability. These kind of models handle that. So the big splash that came out early this year was Google had bought a company, 4 guys, $600 million US, and what came out of some of the really interesting work they're doing is that they've got a computer neural network that can learn how to play video games at a professional level purely by just giving it a virtual joystick and button and then telling it to play games, and it learns by itself how to play games. And that's more than a statistical model now. You can see that it's actually learning how to program itself. I don't want to get into the evil side of that because it's programmed itself to play a game. Doesn't have any intent. It doesn't understand the images in any way. It's not, it's nothing like that. It's just purely knowing. For example, in Pac-Man, it didn't know that eating the cherries allowed it to eat the ghost, right? So it's still not that sophisticated. This came out 2 days ago. Visual Question Answering, or VQA. I googled VQA and got the Victorian Quidditch Association, so that's a bit weird. But you can ask questions. Is there a baby in the photo? It says yes. Where is it standing? It says in the bathroom. It's never seen this image before. What's it doing? It's brushing its teeth. And it's masterful what Facebook have done is they've advertised this as allowing people who are blind to get a description of the images. Which is, it's really touching. But actually they just want to sell you more ads, right? So basically you've been giving them labelled images that they've been running machine learning on for years. And they've got huge amounts of data they're training on. And so they can know where you are, who you're with, what activities you're doing, and just by the background they'll know whether you're in Fraser Island or wherever. So it's amazing what they're doing in the background, all in the purpose of selling you new ads. So it's really hard to get people in healthcare to do this stuff because they're all off at Google and Facebook selling ads. But we can use this kind of technology in healthcare. So this is a close-up of so this is a description. So people, you can get quite natural language descriptions of what's going on. Just to give you a feel for the amount of data you need in iteration. So this is this guy Karpathy, who's a grad student at Stanford, was feeding a network War and Peace. And after 5 iterations of training, then he tells it to generate text in. And what he's doing is not telling it to understand the words, just the sequence of letters. He's just giving it a sequence of letters and telling it to learn about that text. After 2,000 iterations, it's actually generating things like quotes, expressions, and full stops and sentences. And it's really teaching itself English just from letters after 2,000 iterations. So these networks are intriguing. They do some pretty interesting stuff. So what's changed? Okay, networks are deeper. They're doing kind of interesting things in the different layers. There's been progress in networks for image recognition called convolutional networks, in language and sequences called recurrent neural networks. They require a lot of data, so we've been having a lot of a larger data set. So Stanford built 14 million plus labeled images to train their image networks. But the biggest improvement is actually the computer power. And I think earlier Anthony was talking about the lowering cost of genetic testing, but the cost of maths processing, what's called GPU graphics processing units, GPU processing, has just also followed that path in the last 20 years. So it's easier to really look at this. So on the right, so this is Lara Croft from a game called Tomb Raider. I'm not trying to be sexist or gratuitous, but actually it was one of the first early 3D games, and we have some really good comparisons. So this is Lara Croft in '96 on that side, and this is 2013. That is just a picture on about 3 or 4 polygons. This actually has muscle models, multiple layers of skin, hair models, and the 2015 version of Lara is even more impressive. This is not a pre-rendered Pixar movie. This is real-time hair, muscle, lighting, reflections. You know, it's just amazing, and it's really graphically describes, you know, the power that's changed from 96 to today. So, in terms of pathology, there's been a bunch of work in looking at histopathology, and it's more in a competition sort of sense. This is a group out of Switzerland, I think, and so they've been identifying mitoses and being able to look at the rates of detection of mitoses in histopathology, just giving it slides, and it doesn't matter their rotation. And previously it would have taken 5 months to train on a computer, on a reasonably fast computer, whereas now using the graphics processing units, it's in days. Literally gone in the last few years from having to spend a year training a network to a week. Google, for example, as I mentioned earlier, spent days on 800 computers, whereas now they can do that on very few computers. So a lot of this progress can be done with people on gaming machines, you know, as an individual, rather than having to hire supercomputers. So it does all this identification through the networks and has reached expert performance in its prototypes. So why aren't we using it? Why aren't we rolling this out? Well, the problem is that they kind of go wrong sometimes. And it's easy to think, because they're so good at describing what they see, that they're actually thinking in the same way that we do, but they don't. They just see rows of pixels. So up the top there, well, you can't see that too well, but it thinks this is a lesser panda, and this is a peacock, this is a baseball, and you know, so forth, electric guitar, you know, so forth. So, and it thinks this with huge confidence. So when they go wrong, they kind of go wrong in, you know, in a pretty spectacular way. So there's a bunch of technical issues around where neural networks and deep learning are a bit of a problem. Part of the issue is, yes, they're good for prediction, but actually we need to be able to take that and really incorporate that with other sources of data and other kinds of models and statistical models. So the fact that a lot of machines don't output probability, which means we can't integrate them with patient utilities for decision making, if we're trying to do decision theory. Also, the way you train a network, you see, it takes a long time to train, but they're quite quick to run, but they're not easy to move from one location to another, because what you're doing is you're embedding the priors or the prevalence of disease in with the likelihoods, and you're running those through, so you have to retrain them a lot. And there are some ways around this, but they're a bit more complicated. And also setting the parameters, or how deep, how many nodes, and all that stuff is still a black art. You kind of have to trial and error it. So it's certainly a lot of areas. I mean, I think our view, the reason I'm interested in them is we're looking at them around not clinical advice, but around patient flow, identifying early identification of indicators that might lead to length of stay, chronic disease detection, and eventually I think we'll get to integrating more with genomics and image analysis. But we just need a lot more data, a lot more high quality data with outcomes. I think we have to be careful in how we roll this out. And as we were talking about before, we might make some technological improvements, but actually integrating those into clinical workflows is always a challenge. I think a lot more high quality data is required, and I think this is an important area because, as I was saying before, I truly believe that the sustainability of the healthcare system really relies on us being able to allow clinicians to concentrate on the individual while the machines worry about the many, and when, because we're just not great at that. The logistics and all of that stuff, we're just not great at. And I haven't talked about areas in artificial intelligence planning and a few other areas that are also progressing rapidly to help organise plans. And I guess the other take-home message is, video games are really pretty cool these days. So, thank you very much. you.